Ó, meu amigo,
E aí, tudo bem aí? Como é que estão as coisas?
não tô bem como você, mas estamos indo.
Direto do centro cirúrgico aí?
Eu terminei o consultório, mas depois eu vou começar uma robótica.
Hoje ainda?
Opa, tá marcado para as 9.
Ai, que medo. São Paulo e seus horários.
São Paulo é o horário. E amanhã eu começo às 5 também, porque você não tem o robô.
Nossa. Você tá operando... Qual hospital que você tá?
Hoje eu tô no Vila Nova. Ontem eu operei no 9, hoje no Vila Nova, amanhã eu tô no Einstein.
Caramba. Correria também, né?
Tô aqui. Você pode ver quando vocês me falam de filiação e tal, eu não foi em nenhum hospital, porque, puta, como eu não sou bandeira de nenhum me paga, então eu
Sim,
vou onde o meu paciente quer.
claro, não, sim, sim, sim. É, que nem a
E
gente com o
o.
Marcelino. Marcelino no hospital, que nem você ali, o Einstein. É o corpo aberto, né?
é, então, Einstein, Vila Nova, 9 de julho, eu vou neles, nas minhas aulas eu não ponho nenhum, porque daí eu não compro briga nem partido com ninguém, e é a melhor coisa.
Ah,
Agora,
sem dúvida.
impressionante como eu participo, primeiro, obrigado, eu participo desde o primeiro evento seu. Aumentou muito esse evento, né?
Sim, sim, sim. É, esse é o quinto, pra
Impressionante.
você ter uma ideia. Esse é o
Ah,
quinto e ficou uma coisa tradicional e internacional também. Muita gente é da América Latina, né?
não, mas eu sei porque assim, eu participo dos cinco. Impressionante como cresceu e como a gente vê aqui em São Paulo gente que está assistindo mais.
Sim, sim, sim. O pessoal assiste muito depois no YouTube assim, eu
É,
tentei fazer esse ano muito mais específico, não sei se você percebeu,
sim.
pelas aulas, assim, não uma coisa assim, para quem faz o negócio mesmo, sabe?
Uhum. No
Eu tentei
centro, a
fazer,
gente percebe isso pelos temas, né?
é, falei, olha, talvez o público vai ficar mais restrito, mas acho que vai ficar mais especializado também. Então achei que fazia sentido.
Ah, total sentido, total.
É, então, sei lá, mas obrigado. E obrigado por estar nos cinco, ter sempre aceitado, estar disponível
Cara, para mim é um
na tua
prazer, João.
agenda terrível.
Fala, Lê!
E aí,
Olá, e aí,
tudo bem?
Nicolas, e aí, Beloto?
O
Tudo
Alessandro
bem,
é outro
Ale?
também
Tudo
que tá desde o
jóia?
primeiro, acho que junto todo ano, né, Alessandro?
Ô, um prazer, estamos aqui. Alexandre é
Sempre
guerreiro.
altíssimo nível. O Sukanji, ele mandou um vídeo no Drive, porque ele ficou com medo que não sustentasse, mas ele vai estar online junto com a gente, tá?
Tá, mas
Ah,
daí
que
você vai jogar o vídeo dele, e daí depois, quando acabar o vídeo que ele faz, daí vai entrar mesmo real falando, é isso?
Eu acho que sim, acho que é isso que
Porque
ele pretende,
daí,
pelo menos.
porque se é vídeo, às vezes qualquer coisa de conexão para o vídeo, né? E se ele já
Sim,
mandou a aula pronta?
sim, eu acho que sim. Eu acho que ele vai
Entendi.
fazer dessa forma. Ah, sim, eu acho que também, se o dia robótico bom é justamente ver os vídeos mesmo, né?
Sim.
Fica bom. Aí a discussão faz ao vivo, né?
Sim, sim, sim. É isso que ele
Tá
sugeriu.
ótimo.
Que ele está em algum congresso, não sei aonde, ele não está nos Estados Unidos.
Eu acho que ele
Tá.
está em Singapura, não é?
Singapura? Eu não sei, o Eduardo Fernandes está.
O
Até que foi o
Edu, sim, o
motivo que
Edu
eu.
eu falei com o Edu e falei com o Benedetti. Benedetti falei antes de ontem.
Aham.
E daí, esse final de semana eu tava com o Goro Honda, né? Puta, o cara é um animal, eu vejo como ele opera mal. Puta que pariu.
Ah, lá
Ele
em
opera
Joinville, vocês
muito.
estavam juntos?
Mas hoje ele é chefe do grupo de fígado de Tóquio, né?
Sim.
E o Tosai o de pâncreas. Mas eles
Uhum.
têm uma habilidade muito fora da casinha, né?
É, mas é grande serviço mundial, né? Faz todo dia se quiser, né?
Ele falou assim: não, a gente está fazendo pouca. Eu falei: quantas hepateias laparoscópicas você faz? Ah, ano passado 150. Porra,
Então, não. É
é
diferente,
muita
né?
coisa.
Eu faço atividade de consultório, né? Não tem como, né?
É.
Vocês lá no AC Camargo é diferente, é movimento de serviço também, né, Alessandro?
Não, acho que isso ajuda muito, né? Uma centralização, assim. Lá
Sim.
no Japão é muito regionalizado, né? Tipo, hoje teve o quê? Duas pancreaté, uma hepatia direita e uma PCC, uma pancreaté corpo caudal.
Uhum.
Então, em geral tem, é que assim, também tem uma certa sazonalidade, sabe? Tem dia que
Sim,
tem
sim,
duas, três
sim.
GDPs, daqui a pouco
Sim,
passa uma semana meio paradona, é
sim,
meio louco isso também. Mesmo lá, às vezes tem um pouco de oscilação.
sim, sim.
Mas que é um puta movimento, né, Ali? Você
Tem,
concorda? Quantos hospitais hoje no Brasil tiveram duas GDPs, uma hepata direita e uma PCC?
não, é difícil, acho que é difícil.
Puta movimento.
Eu também acho, para esse tipo de cirurgia não é bariátrica, não é vesícula, né? Pô,
E a gente também, estamos em cinco, seis cirurgiões, né? Tá certo que a gente se ajuda, né? As cirurgias maiores, a gente sempre dá um respaldo para os outros, para ter os residentes, mas a gente está sempre por perto para entrar
sim.
um pouco na fase mais caprichosa ali da cirurgia.
Mandar uma mensagem pro Sucande só para, né?
Ele já tá online, acabou de entrar.
Ah, ele tá? Oh, acabei de
Tá.
mandar. Dr. Sucandi,
Hey, good morning.
hey, how you
Oh,
doing?
I guess
Good
good afternoon
morning.
there. How are you? How are you guys doing?
We're
Hello, how are
great.
you?
Good, good. Thank you for the invitation for this talk.
Are you in Singapore?
No, I actually I finished from Singapore. I'm attending a family wedding in
Ah,
South
ok.
Africa. So I'm in South Africa right now, actually.
Nice.
Great.
Yeah, yeah. Um, I send it the recording because I want to make
Yes.
sure that the transmission
Yeah,
is
yeah,
smooth.
yeah.
So
Would you like to try it on
when we are
now?
ready, we can play it, huh?
Would you like to try it now or I don't know?
Yeah, yeah.
Okay.
I mean, I think it's okay, right? It's good.
Okay. Just a moment,
Yeah, yeah, no worries.
please.
Yeah,
Você podia. Ah, ok. Você podia passar o vídeo, por favor? Ah, ok. Pode passar, por favor.
Eu acho que tá indo já, é que tem a
Tá
primeira
indo?
parte, acho
Ah,
que
tá, tá,
é.
tá. Agora eu vi.
Vocês estão ouvindo o som?
Não. Uh, we're not. Is in your video supposed to have your description or something like that? I mean,
yeah. It's supposed to have the sounds. Yeah.
yeah, because we're not listening to anything.
Oh, so it doesn't have a sound at all?
No, not here, but
A
there
pessoa que
is
está
an audio.
pessoa que tá projetando também não ouvia som? Será que o som deles pode estar mutado, alguma coisa assim?
Eu já estou escrevendo
Maybe
aqui
the
para.
video was in mute.
Ela vai tentar de novo. She's gonna try it again.
Yeah, yeah. Try it again.
She'll try to share again, this time with audio. Still with no sound.
Ah, okay. So if that's the case, then I'm gonna do it live then.
Yeah, I thought about so yeah.
It's
So she
okay.
can play the video and then if you don't mind, could
Yeah,
you?
I can do live as well. I just want to send the video because I'm afraid that the connection may not be good connection, but seems like this is a pretty good connection.
So you want to try by your own? Is that what you mean?
Yeah,
Oh,
yeah.
okay.
Let's
So,
just try it live.
so I'm gonna ask her to stop.
Yeah. So I'm going to hang on there. I'm going to share screen now, right? So you will have to quit the sharing screen and I will
Yeah, yeah.
share my
I'll do so.
screen.
I'll do so. Yeah.
Yeah.
My name is Dr. Santos Kandi. I would like to thank you for the
Ah,
opportunity to give
that's it.
talk
That's
to
it.
this wonderful conference in Brazil.
Oh, this word.
The voice came out.
Yeah, yeah. So okay.
So, yeah. So we can just use this voice.
Yeah, certainly. So just before we start, we have the routine of presenting everybody. So
Yeah.
Dr. Sukane, this is our first version of this HPB course, the fifth year in a row. And this year we had 1,200 people enrolled. So it
Wow.
became, yeah, so it became quite a traditional HPB course. And normally the attendees are not only from Brazil, but also from all Latin America. And so thank you very much for being with us this year again. And just before presenting you, just gonna thank the my friends, Dr. Belotto from São Paulo, HPB surgeon. So he's been in every course for for the last 5 years. So he's been in the first, the second, the third, the fourth, and now. So thank you very much, my friend. Dr. Belotto is someone who has a huge experience in the HPB robotic surgery in the country. So I'm very proud that he accepted again to be with us.
Inclusive, thank you for inviting. Professor Tucandi is very good to stay here never. Your presentation in Rio de Janeiro in the surgery oncology
Yeah.
is very good.
Yeah. Thank you. Thank you very much.
Thank you.
And also Dr. Alessandro, also from São Paulo, HPB, an oncological surgeon, GI surgeon. He also has been attending most of our courses all over those 5 years. And once again, he accepted to be with us. So, Dr. Alessandro Diniz, thanks again. Thank you very much indeed.
Thank you, João. My pleasure, my friend. I'm very honored to be here today with Dr. Sukandi, fantastic and skilled surgeon, HPB surgeon. So I'm ready to learn a lot from you and all the colleagues here. Thank you.
And Dr. Sukandi, he's HPB robotic surgeon at Advent Health, Tampa, Florida. He's one of the world main authorities in robotic surgery. And again, so this is the second time he's with us, and every time is a pleasure to have you, and especially to listen to you. So thanks, and I wish you have a great. All have a great lecture. Thanks again.
My name is Dr. Santos Kandi. I would like to thank you for the opportunity to give talk to this wonderful conference in Brazil. My topic today is the limits of robotic HPB surgery in 2025. I would like to thank you, Professor Nicolucci, for the invitation to share this interesting advancement. And I'm sure this is only the beginning, and things will become more in the future as the robotic surgery become widely adopted and widely available across the world. Limits of robotic HPB surgery in 2025. So robotic liver surgery is gaining adoption mostly because of the complex hepatobiliary resection and late liver transplantation. The simple minor resection are done laparoscopically. However, the more complex one now is moving toward robotic. And robotic is preferably applied in cases where there is a difficult tumor location, need for portal lymphadenectomy, and vascular or biliary resection with reconstructions. In this talk, I will touch up on 3 subjects. One is robotic Whipple for pancreatic cancer. Number 2 is perihallar cholangiocarcinoma. Number 3 is liver transplantation. Due to the time limitation, I would focus more on the B and C, while I also mentioned to you the advancement in the pancreatic operation, in particular Whipple operation with vascular reconstructions. So this is a technical description which I reviewed. It's a paper that came from one of the very good Brazilian surgeons. This is where the robotic surgery really helpful in pancreatic cancer surgery, where there is involvement with the SMV and portal confluence from the uncinate or head tumor, where the resection of the portal mesenteric axis is needed. And you can see here this is an example of the very useful technique in robotic surgery where a piece of the portal vein needs to be resected and replaced with a tangential patch on the side. This is actually quite doable to do it in robotic, which enable us to do now robotic vascular reconstructions, both in the pancreatic, liver, or biliary operation, as well as transplantation. This is another paper also from Ugo Boghi from Italy that shows a similar technique of side patch using both pericardium of the SMV portal vein involvement, and I think this is now becoming routine for pancreatic cancer operation for local advanced tumor. This is the advancement, and I think this is something that is maximized in robotic pancreatic surgery, and it is no longer a limitation that the surgeon have to do this correction operation to an open approach. Now, moving on to the classic tumor resection. This is another very useful application of robotic surgery where it is almost reaching the limit. Obviously, the limit will become higher and higher in any of this operation. However, we feel like today the limit is there where we are in terms of hepatopancreatic biliary resections. So it is a difficult cancer to treat with frequent, again, vascular invasion with local recurrence. The issue is the biliary anastomosis and potential vascular reconstruction, also not ideal for laparoscopic. Otherwise, people have to do an open operation. At the beginning, the initial laparoscopic series mainly talk about the Klaskin 1 and 2, which is technically easier operation. However, the outcome were not very satisfactory, and the robotic experience started to gain more interest with excellent, at least short-term outcome in this operation. And this moved the needle, moved the ceiling up toward more and more robotic hepatobiliary complex operation. So this is the history of the disease. This is discovered by Professor Gerald Klatskin, who worked at Yale, and he's known as a doctor of weird hepatobiliary diseases. He developed an atlas for all the unusual hepatobiliary pathology, and also he discovered biopsy technique for liver tumors. As I mentioned before, Klaskin tumor is a serious operation with serious postoperative course. You can see here, this is the paper from Nagoya, Professor Nagino and his junior partner published that the mortality up to 7.3% in Asian series, and it's up to 13.3% in Western series. As comparison, Whipple mortality is only about 2%. So anatomically, the most common biliary tract cancer type is actually perihallar cholangiocarcinoma, which reach about 56% compared to intrahepatic and distal cholangiocarcinoma. And we utilize a Bismuth-Corlett classification for this lecture purposes. The technical evolution started from open, moved on to laparoscopic, now computer-assisted robotic surgery. In our center in 2019, we started to undertake this operation with robotic approach, having done 150 robotic major hepatectomy. At that time, we published our series in 2021 of 15 patients of robotic perihallar cholangiocarcinoma, age 74, BMI is 24, and the operative time is 453 minutes. This is obviously a long operation. However, patient did not require ICU stay, and long-term stay is also quite limited. The R0 resection is about 90%, which is excellent, acceptable for Klaskin tumor resection. The second series that we published in 2024. 3 years later, has 23 patients. This was an oral presentation at HPBA. It also shows encouraging outcome as we continue to do this, and R0 resection is about 87%, and postoperative complications about 17%, which is also acceptable for cholangiocarcinoma, which usually in most paper has postoperative complication about 40%. So this is a European series of Klatskin tumor resection once we started this endeavor. And you can see here, this is from Padova, Professor Cillo. He published the series of first European center with Klatskin type 3 and 4 were excluded. So all of this structure type B, which is a left appendectomy, and blockaded with root to the right. And you can see here the selection criteria is quite strict. So only 4 patients included, and the patient cannot have major upper abdominal operation. The important lesson to take home here is 25% of patients actually had unplanned conversion due to short mesentery for biliary reconstruction. So I think this is one of the limits of robotic surgery. It is quite difficult to bring up the mesentery toward the liver if you need to do reconstructions of the vascular or biliary tract, because we don't have our hand in there to push the basomesentery cephalad to do the anastomosis without tension. So the patient got converted because of that. 25% also patient had R1 resection, and 25% have a grade A bile. This is the second series from University of Modena in Italy that examined cholangiocarcinoma patient also robotically, and you can see here 21% of patients have a 3A Klatskin resection. So this is a more serious operation within this series. One thing I want to point out is about 50% of the patient were actually included as a 2-stage ALP operation for perihilar cholangiocarcinoma, and most importantly, majority, about 86% of the patient actually had robotic as a first stage ALPS and the open as a second stage ALP for perihilar cholangiocarcinoma. So if you can see if this is a limit of robotic surgery, this is probably limit of robotic surgery. As you can see here, many of the second stage ALPS for perihilar is still done open, 86%. So from a technical perspective, there is still something that we still have to use an open operation, or at least we feel open operation is a better technique to achieve what we need to do. The lymph node retrieval alpha is excellent with robotic. This is the first international series that we published, putting together the experience from Tampa, Lisbon, and Modena. Myself, Professor Hugo Pinto Marquez, and Fabrizio Di Benedetto, and we published in Annals of Surgery in 2024. You can see here we have 38 patients. I encourage you to read this paper, and the patient is well prepared, well selected patient. Majority of the patient have preoperative biliary drainage because we are targeting the total bilirubin has to less than 3 prior to the resection in order to optimize and reduce postoperative liver failure, which is known to be the killer of this cholangiocarcinoma. Operative duration is still long, 481 minutes, and even with more cases, we still have approximately more than 400 minutes of operative time. I would like to highlight that the number of anastomosis has increased. At the beginning, we only choose the case that is requiring single anastomosis, but now we are doing this even with cases with multiple anastomosis, through 2 or often 3 anastomosis, which you will see in the video at the end of this lecture. So we are increasing the limit of robotic surgery for perihilar cholangiocarcinoma resection as we gain more experience. The oncological outcome is quite satisfactory. Again, this is another limit of robotic surgery that we continue to increase the vascular reconstruction and resection. Even in the robotic series, we have 8% of patients require tangential excision and end-to-end resection of the portal vein or hepatic artery. You can see the picture here, end-to-end portal vein, to the right portal vein for a patient that has bifurcation tumor involvement. So again, we are elevating the limit of robotic surgery to also include robotic vascular reconstructions, which otherwise impossible to do before the robotic was invented. Post-operative complication is a 42%. However, it seems high, but it's actually not high for perihilar cholangiocarcinoma, taking all comers. And you can see here the picture on the right side. We are doing ductoplasty, putting together of two ducts in order to do a single anastomosis. As we know that the number of anastomosis is a determining factor for post-operative bile leak and post-operative stricture later on. So all of these biliary maneuvers is done robotically, and it's no longer have to be done through an open approach. Again, mortality is quite minimal, 3% for perihiatal carcinoma with well-selected patients. The unmatched robotic versus open cohort, you can see here the robotic obviously longer, 481 minutes versus 420 minutes. The blood loss is much less when compared to open. Lymph node harvest is still adequate, more than 6 lymph nodes based on the AGC requirements. Postoperative complications 42% compared to 72% in open. As you can see, open in this whole cohort is obviously a bigger operation, and I would like to highlight it's an unmatched cohort. However, we can see the difference between the two cohorts. Length of stay 6 days to 15 days between robotic and open. The video clip shows the transposition of the root limb through the transverse mesocolic window. You can see here all of this can be done robotically now, further elevating the limit of robotic surgery, even though it is quite challenging to reach if we have to do Klatskin 4, for example, where the anastomosis is very high up at the halal plate, and as I mentioned before, lifting the mesentery is still a bit of the challenge in robotic surgery, even with the advanced bed positioning. This is a video clip of main portal vein resection and reconstruction, which I performed probably 4 years ago or so. There's a small tumor in the ventral aspect of the portal vein, and I encourage the surgeon who are interested in robotic surgery to start with this as relatively straightforward steps. In vascular constructions, the lesion is in the ventral aspect of it. It can be easily cross-clamped without the need for heparinization, and the wall of the portal vein can be resected and reconstructed without much difficulty. The video clip on the right is the right hepatic artery resection due to tumor involvement. I went up to the secondary radicals where I disconnected the right anterior and right posterior hepatic artery, which I put together. And then I anastomosed the right hepatic artery to those two secondary hepatic artery branches. So 3 bulldogs were placed, one on the right hepatic artery, one on the right anterior sectoral hepatic artery, and one in the right posterior sectoral artery, and the anastomosis is done with the 6-O-proline. You can see here all of this done with the robotic system. The Doppler ultrasound at the end of the reconstruction shows good arterial perfusion to the right hemiliver. Therefore, the right lobe can be preserved. This is another video clip also with the Klatskin resection of the mid-bile duct cancer in a 92-year-old patient. Again, the extrahepatic bile duct has been disconnected from the pancreas and is attached in one location to the main portal vein. Due to the concern of portal invasion, I cross-clamp preemptively, and once the proximal distal control is obtained, we can be aggressive in resecting the tumor mass, even resecting a little piece of the wall without any problem. This can easily be done with robotic, again, further elevating the limit of minimal invasive laparoscopic surgery. This is another video. I've shown you the main portal vein, hepatic artery now is the middle hepatic vein reconstructions. This is a video of breast cancer 5 cm in size that is in contact with the middle hepatic vein, and this patient have a dominant middle hepatic vein which is draining a large portion of the segment 6 and 7. Therefore, we want to preserve the middle hepatic vein to avoid congestion of the venous outflow from the right posterior sector. In this operation, you can see here we skeletonize the middle hepatic vein medial wall. The tumor has been disconnected from the future of a remnant, and now we are walking on the wall of the middle hepatic vein with the 2 Maryland bipolar technique. This is no CUSA. I know his CUSA is developed, and it is not out yet, but this dissection is done without CUSA. The bedside assistant is helping with the laparoscopic suction device. The middle hepatic vein is skeletonized very nicely with limited bleeding, And I place a curved bulldog clamp. This is a scannel bulldog clamp that is used also for transplantation, for any vascular and Whipple and everything. And I resected the medial part of the middle hepatic vein. And now we have visualization to the lumen of the middle hepatic vein. We run the suture in the tangential fashion. This is almost like a type 1 portal vein resection reconstruction. However, for hepatic veins, the classification has not been invented. I guess we'll call it type 1 as well for the main portal vein. And now I close the portal vein, open the bulldog, and the portal vein inflow is preserved. There's no congestion of the right anterior sector of the liver as well as right posterior sector of the liver. Everything looks good. This is another a description of robotic vascular dissection and reconstruction for a Klatskin type 3B tumor. You can see here the proximal branch of the left portal vein is thickened, and there was a tumor concern here. Therefore, I put a cross clamp on the main portal vein as well as the right portal vein, and a bifurcation is reconstructed in a transverse fashion. We actually checked the thickness of this, and there was a tumor there. However, the thickness that we left behind is fibrotic without any evidence of carcinoma there. It's just a small plastic reaction. The color Doppler was done at the end. The portal inflow is excellent, and the patient is doing well post resection of extended lipopatectomy for Klatskin type 3B tumor. Even for biliary benign diseases, this is a type 1 colorectal cyst with an 8 cm colorectal cyst resected. The patient happened to have a separate insertion of the right posterior bile duct requiring 2 anastomosis. Now, the biliary anastomosis, more than one, also can be easily done with a robotic approach. This is a 4-0 barb suture. I have a video next in the slides, and you can see here this can be done easily. This is another perihilar cholangiocarcinoma. Again, the first anastomosis is done with absorbable barb suture. It is a running fashion. The dorsal anastomosis was done first. Once the anastomosis is finished, the first one, we move on to the second one. This is finishing the first one, first anastomosis of end to side running hepatoduodenal anastomosis. You can see here we are able to see with the needle placement. The two needle holder is used simultaneously to look at the lumen of the small bile duct in order to be able to place the suture well. This second anastomosis is done. The assistant is helping with the exposure. Again, similar technique of running suture is done. We are able to see the bile duct very well. This is above the halar plate, and this operation otherwise is very difficult to do laparoscopically, and even open is also difficult to do, and robotic is again elevating the limit of a minimally invasive HPB cancer surgery. This is the front wall of the second anastomosis being performed, and the anastomosis is completed, double anastomosis without any problem. The ductoplasty, putting together two ducts, is also easily done for cancer surgery, as well as now in a transplantation. The ductoplasty using 5-OPDS or 6-OPDS, those two neighboring ducts can be put together to reduce the number of anastomosis with robotic system. This is another case that I want to show. This is a difficult tumor IVC dissection in a patient with metastatic colorectal cancer liver metastasis, which was treated with a Y90 radiation lobectomy with TARE, transarterial Y90 radioembolization. You can see here there's a big tumor with a very, very obvious IVC contact, and the right lobe is atrophied because it has been treated with high-dose Y90. These are 3 reconstructions of the tumor that is really holding the IVC lateral wall. In most cases, this is an open operation. However, in this case, we are able to do this minimally invasively with robotic system with obviously backup plan to do a vascular reconstruction robotically, if possible, and open as a second backup if it's not possible. The right hepatectomy now is done. You can see here the tumor area is very sticky to the ventral wall of the IVC. We're separating it with a very, very gentle maneuvers from the double barrel bipolar technique. We are able to separate this tumor contact with the lateral aspect of the IVC. The right hepatic vein is skeletonized, encircled with the trio silk stapled, and now we have the right inferior hepatic vein, which is attached to the cava as well. Now as a second staple is placed, the tumor is removed. The patient has minimal invasive operation for such a difficult dissection with the tumor contact to the inferior vena cava. And even if the FAC needs to be resected, and obviously we are able to cross-clamp the vena cava robotically now to be able to repair the IVC. This is another difficult dissection of multi-organ tumor involvement. This is a patient with prior liver ablation at a different institution. Now have a tumor recur on the right posterior sector. Patient underwent extended right posterior sectionectomy, and the patient happened to have a diaphragm involvement, which required end block resection of the diaphragm and a closure of the diaphragm in the robotic fashion. You can see here after the right posterior specimen is disconnected, the tumor was very stuck to the diaphragm. We have a difficulty actually mobilizing the specimen, and we find out that the tumor has invaded the diaphragm itself. Therefore, we have to remove a small, actually a big piece of the diaphragm. You can see the lung is on the background of this scene. There's a little bit of blood in the right hemithorax. We suck it out. We close the diaphragm with barbed 2-Vloc suture, and this eliminated the need for open operation. Patient did very well. Chest tube was placed on the right side of the hemithorax, removed on day 2. Patient went home from day 3. So again, the limit of robotic surgery has become higher and higher, but obviously still a limitation compared to open today. Robotic resection of type 4 perihilar cholangiocarcinoma, minimal invasive technique in biliary cancer surgery. 71-year-old man presented with jaundice and weight loss. He doesn't have significant past medical or surgical history. The workup included CT and MRI as well as EUS and PET scan that showed bismuth type 4 perihilar cholangiocarcinoma without any evidence of extrahepatic disease. The anatomical evaluation included the reconstruction that showed 21% of the specimen volume. This is the CAT scan, and the PET scan that showed tumor on the hilar plate bearing to the left side of the liver. We can see dilated intrahepatic bile duct much more on the left considered to the right. This is the port placement for this operation. The plan is to do an extended left hepatectomy with end block biliary resection. The bile duct will be resected up to the secondary radicals, where the right anterior and right posterior bile duct will be separated, and this requires multiple anastomosis. The operation began with portal lymphadenectomy, which was done in a meticulous fashion with the intention of gaining more than 6 periportal lymph nodes. This is the right gastric artery being clipped and divided. The main energy and small branch of the GDA were ligated and clipped and divided. This gave us more clearance for the radical lymphadenectomy. Another ventral branch of the proper hepatic artery being ligated, clipped and divided. All the lymphatic bearing tissue around the portal vein and hepatorenal ligament is being skeletonized and divided. This is the distal bile duct being transected. The intraductal biliary stent were removed. The distal duct were closed after confirmation of negative margin on the distal CBD. Intraoperative spyglass was performed to confirm the location of the tumor, which is a bismuth 4. The distal bile duct was then closed to avoid excessive bile leak. The cholecystectomy was then performed. We moved toward the ventral aspect of the hilar plate, where the branch of the right hepatic artery being isolated, transected. This is the dissection of the hilar plate, which proven to be difficult. The left hepatic artery being skeletonized, ligated, and divided. As mentioned earlier, in this operation, the patient will have extended left hepatectomy with end block biliary resection and Roux-en-Y hepatogenostomy to both right anterior and right posterior duct separately. Segment 4 left hepatic artery branch is also ligated, clipped, and divided with the goal of gaining complete control of the left hemiliver inflow. Attempt to skeletonize the left portal vein was also performed. However, we encountered bleeding during this part of the dissection. The mobilization of the left lobe was then continued. The accessory left hepatic artery was then skeletonized and divided. We proceeded with dissection and division of the short hepatic veins of the inferior vena cava. In this operation, the carotid resection was included as part of the left extended hepatectomy. The spigal lobe is retracted with bipolar forceps to show the short hepatic veins, which was skeletonized, ligated, divided, and separated from the inferior vena cava. This is helpful for open booking the liver. The liver parenchymal transection is now started with crush clamp technique. We came down to the halon plate when the liver is already split. This is the right anterior bile duct and this right posterior bile duct, which was divided separately. Both margins were sent to pathology and both were confirmed to be negative for malignancy or neoplasia. We then continue cephalite to split the liver and block with a carotid lobe. Parenchymal liver was applied in order to facilitate handling of the left portal vein that was bleeding earlier. Ligation of the left portal vein was then done with a fluoroproline and it was reinforced with clip. Once the left portal vein is divided, we essentially now about to complete the left hemiliver transection. The distal part of the portal vein was then ligated temporarily. The crossing branch between right and left hemiliver was clipped and divided intrahepatically. At this point, we are splitting the carotid lobe. Extra margins were obtained from this and also confirmed to be negative for malignant neoplasia. We march up toward the root of the left hepatic vein as it entered the inferior vena cava. At this point, we can see the inferior vena cava is shown on the bottom aspect of the screen. The left hepatic vein is stapled with a vascular white load stapler and the specimen is removed. We then started with the reconstruction part of the operation by creating a 60 centimeter of the rulim for the anastomosis. A side-to-side stapled jejunostomy is then constructed. Opening on the alimentary limb as well as the biliopancreatic limb was made. The common introitum was closed with a running imbricating Vloc suture in a watertight fashion. And once the opening is closed, we are now finished with the staple side-to-side jejunostomy. We proceeded with the retrocolic Roux-en-Y anastomosis to reduce tension. The first anastomosis is between the accessory right hepatic bile duct. The dorsal aspect of the anastomosis was run. The ventral aspect was handled with interrupted suture due to the small size of the duct. This is the first out of 3 anastomoses. The accessory right inferior bile duct was realized to be larger enough for anastomosis at the end of the operation where bile started to drip from that. A 4 French pancreatic stent was utilized to stent the anastomosis due to the size being less than 5 millimeters. This is the second anastomosis between the right anterior bile duct to the opening in the jejunum. It was done in a running fashion, and this is the last anastomosis between the right posterior bile duct to a third opening in the jejunum, which is also created in a running fashion. A small pancreatic stent was again utilized to help stenting the right posterior bile duct, which is quite small. Once the stent is placed, the frontal aspect of the anastomosis is now completed in a running fashion without much difficulty using robotic system. In this patient, there are 3 separate anastomoses, which are approximately 3 centimeters apart. It is not possible to create a single anastomosis due to the case being classic type 4 and required a radical resection where each of the biliary openings were farly separated. We then suspended the rulim at the end, and this gave us a completion of this resection. The operative time was 8.5 hours with 100 cc of blood loss. Patient did not have any possible complication. He was discharged home on possible 7 without drain, and at 1 year follow-up, the patient was doing well without complications. The pathology showed tumor was consistent with cholangiocarcinoma within 2 cm segment on the common hepatic duct up to the bifurcation. Surgical resection margin was negative for malignancy, and we gained R0 resection margin. I just want to briefly mention about this currently ongoing international studies involving several robotic centers around the world for perihilar cholangiocarcinoma. We have 440 patients open and 70 patients robotic. We do a prevalence score matching down to 77 open and 77 robotic. You can see here the outcome is quite good with robotic. The operative time is obviously still about 8 hours. However, the operative outcome is quite satisfactory with adequate lymphadenectomy, and post-operative outcome is also acceptable. And obviously, this data is more convincing that the limit of robotic HPB surgery continue to increase now, even with multi-center studies that involve many centers. We can now move toward robotic classical tumor resection. The overall survival as well as disease-free survival is quite superimposed between robotic and open, indicating that there is no oncological concern by performing this patient minimally invasively. At the beginning, we were criticized by many established open surgeons that the minimally invasive may not give the same oncological outcome as robotic, but this answer will come very soon. This is just an article that we published about a year and a half ago of 530 minimal invasive robotic hepatectomy from our centers with 35 classical tumor in there. We also examined our learning curve of 500 robotic hepatectomies, and this is obviously not included open. With open, we have done more than 1,000, and with pancreatic resection, we have done more than 1,500. So the last part of this talk will be robotic liver transplantation. I would mention this very briefly because this is also a field that's moving very quickly. As we know, majority of the transplant field are mainly open field back in the days. However, now the transplant actually, I would say, one of the fastest moving field toward robotic, with the living donor as well as with the cadaveric graft implantation. This is the Professor Rella and his assistant discussing that robotic surgery is disseminating the transplantation forward. Professor Dieter Bruning from Saudi Arabia. I had a chance to be in Saudi Arabia for several weeks to learn how to do robotic donor hepatectomy and liver transplantation, and you can see here they published the first series of robotic recipient hepatectomy as well as robotic graft implantation. The living donor has been done routinely, 350 a year as a robotic operation, and you can see in this publication even the recipient graft implantation can be done robotically, and this is full robotic, not a hybrid approach between open and robotic. You can see here the recipient hepatectomy is done from the left to right. It's almost similar to the hepatectomy for cancer. However, obviously you do not go into the liver. The short hepatic vein is taken from the cava and handled appropriately with the vessel sealer. The portal hepatis is skeletonized and prepared for later implantation. The hepatic vein is stapled with a linear staple, both left and middle, as well as the right separately. This is the biliary anastomosis is being done. You can see here the baldacc anastomosis is done in an end-to-end fashion, as shown in this picture. So the graft implantation, in more detail, it's utilized a 6-0 running Gore-Tex suture to do the hepatic vein to a cave anastomosis. This is a living donor right graft, therefore the right graft is obviously placed on the right side, and the hepatic veins is facing the opening in the cava. This is a German clamp being placed in a tangential fashion, so this is not a cross clamping of the IVC completely. The anastomosis on the hepatic vein side is running technique. Second is the portal vein, also 6-0 running Gore-Tex in the right upper quadrant pictures, and the hepatic artery is done with a 7-0 interrupted prolines, and the last baldacc is done with interrupted 7-0 PDS end-to-end fashion. This is the outcome. 3 donors robotically, they are doing very well. Obviously, this is the healthiest patient that undergo liver harvesting. The age is quite young, 29 to 35 years old. And at the beginning, obviously, the number of bile duct is 1, hepatic arteries 1, portal vein 1. However, the third patient actually have 2 hepatic veins that needs to be implanted. And this is the recipient operation, recipient A, B, and C. You can see here the sodium melt is between 8 to 14. This is quite low melt score. The operative times up to 756 minutes. However, blood loss is quite acceptable for a patient with liver transplantation. The outcome is also doing well. The graft is functioning well post-operatively. This is the first publication of cadaveric graft implantation from the United States, also world. This is utilizing a venous bypass machine. Native liver was removed from a 15 centimeter midline incision, and cadaveric graft, total graft, was also placed through the same incision. The patient required cross clamping of the IVC and, like I said, venous bypass for this case. The suprahepatic IVC was cross clamped with Chitwood clamp, and the infrahepatic suprarenal was cross clamped with 2 robotic bulldog clamps. So you can see here the side-to-side kyphostomy took 17 minutes. Portal vein anastomosis took 23 minutes. Hepatic artery anastomosis took 30 minutes, and the biliary reconstruction duct to end anastomosis is 19 minutes. EBL was 1000 cc with 2 units of blood transfusion. Operative time 8 hours. Recipient hepatectomy took 3.5 hours, and warm ischemia 77 minutes. So you can see here it is technically feasible. It is now being performed in a few centers now, and the technical refinement is being performed as we speak. So this is obviously a much higher limit than what was done in the past in the field of liver transplantation. This is annals of surgery report from our good friend from Lisbon and Modena, full robotic whole graft transplantation. This is 6 patients, a combination of 2 centers between February and March 2024. Warm ischemia time can be a bit long, 55 to 90 minutes. Total surgery duration can be up to 760 minutes. And 1 patient had prolonged hyperbilirubinemia, however, recovered very well without any intervention. Median hospital stay was 7.5 days. This is a technique that was started using a side-to-side kyphostomy. Patient 1, 2, 3 until patient 6. You can see here no patient were converted to open. Surgery duration as mentioned. The length of IVC anastomosis between 19 to 26 minutes. Portal vein between 16 to 23 minutes. And this gave us an idea that how vascular surgery can be done robotically, which is obviously elevate the limits of robotic HPB surgery also. The recipient outcome is quite acceptable. Only 1 patient ever delayed the graft functioning. However, all the other outcomes were good. No hepatic artery thrombosis, no portal vein thrombosis, and the patient doing well. This is again the pictures of how the operation is done. The picture A is a kyphostomy, IVC anastomosis. Picture B is portal vein anastomosis. Picture C is hepatic artery anastomosis, and D is the outcome. So this is something that I want to mention prior to completing this presentation. This is a textbook of robotic liver surgery, which also include robotic liver transplantation on a donor within the book as well. I encourage you to visit this book, and you can learn many things from technical aspect from many experts around the world. So conclusion, the limits in application of robotic technology lies in a complex hepatobiliary resection, pancreatic resection with vascular construction and liver transplantation. The initial outcome is promising. Future works are currently ongoing. As I mentioned, that what was not possible in the past now will be possible now, and in the future will be a routine. Robotic is expected to play more role in the modern HPB surgery and liver transplantation. So the limit of robotic HPB surgery may be having a different definition between now and the future, because what we think is a limit today may not be a limit in the future, and we continue to improve in this field. Thank you very much.
Yeah, we have the impression that the limits are being pushed and pushed and pushed forward, further and further, actually. When we see all the huge HPB surgeries that you have performed, like the Klatskin type 4 and stuff like that, that's already very tough to be performed open. And now the transplantation, every sort of fashion, I mean, living donor or like Hugo, he has already performed, I think, 17 liver transplants, only one death. He presented. He was one of the lecturers in our course here, and so amazing results. Thank you, Dr. Sekandi. I'm gonna leave now. Dr. Alexander has also arrived. I think he's performing in the robotic surgery at the same time. And so I'm gonna leave Dr. Bellotto and Alessandro to ask you. Okay.
Um, Very nice presentation, Dr. Sukandi.
Thank you.
Terrific images. You have shown us that the limits are gone, actually. So you guys are doing wherever we do it open, you can do it in robotic platforms nowadays. A question that I'd like to ask you is regarding training and education in robotics complex case like you have shown, because when you do this in the open fashion, when you're training, you have a fellow in the open fashion, it's much like a forehand surgeon technique, because you are always bedside with your trainee or your fellow, and whenever he's got into a bad situation, you can get the operation very quickly. But for the robotic surgery, sometimes you have to rely a lot on your fellows' skills, as the same way as the laparoscopic surgery. So, do you think the future will have to to offer labs for this training institutions, like whoever wants to have a fellow that's gonna really go into this more complex case? Do you have it's mandatory to have like a cadaver lab or something like that, because just let the guy perform a portal vein anastomosis as his first case, robotic, without doing any lab training, doesn't really scares you? Or how do you deal with that with your own fellows, please?
Yeah, so this is a very good and very important questions. This the training and education in robotic surgery actually has been discussed and started now. So in the US, even in surgical residency, the robotic training has entered as a third year and fourth year. So there is a training curriculum that they need to follow in order to be able to be certified in robotic surgery. This is on top of their open and laparoscopic education. So the fellowship that also offer robotic surgery being very competitively sought. Everyone wants to do robotic fellowship because people feel like this is something that is important, very useful. Therefore, a training program always incorporate a structured, at least is encouraged to encourage structured education. So then the first suturing is not on the portal vein or hepatic veins. They need to train on the simpler cases with the stepwise fashion in the increase in complexity. So SAGES has a program for robotic surgery. There are many independent training programs as well for robotic surgery, and there are many, not many, I would say several societies has offered robotic training as well. For example, ILTS offered robotic training, HPBA, uh, EHPBA. So those are, I think, developing concept in robotic training. so that people do not just jump into the very difficult cases, which can compromise the patient outcome. So they all started with simulation, dry lab, wet lab, and then the patient. So I think it's becoming more structured now, not like used to be. Now there's a minimum limit of robotic this and that before you can go to the next step.
Okay. Piloto, you want to
Hi,
comment?
Professor. Congratulations, your presentation is perfect. And use
Thank you.
bipolar on both hands. In some cases, you prefer one hand bipolar and your hand is another energies versus ciliar or superciliar, the first question. And the second question, when you use spyglass for tratamento intrasurgery de cholangiocarcinoma.
So I will ask the second question first. Yeah, the spyglass we almost routinely use it intrahepatically after we disconnect the bile duct in order to see the limit of the Klatskin resection. That's number one. Number two, also many of these Klatskin tumor become obstructed. So many times they have stones inside the liver. And if you don't see that, your anastomosis, you leave stone above the anastomosis. Because this patient has been obstructed, and you know the obstruction is not happening one day. Those tumors slowly constrict. So sometimes they have a lot of debris within the liver, which we like to flush out with the spyglass. In robotic surgery, the idea is always to try to use two hands to work. So, for example, for parenchymal transection, we use a double barrel bipolar technique. And many times I use Maryland in left hand and a synchrosil in right hand. But the idea is to use two hands to be efficient. The third arm is mainly for traction and positioning, but those two hands has to work simultaneously to make the operation for more efficiently. Regarding spyglass, sometimes we use for a pancreatic duct as well, but it's much rare compared to the biliary work. The spyglass is easily integrated with robotic systems, so and to set it up, it only takes about 10 minutes in our center to do it. So for us, it's very easy to set up the spyglass.
Thank you, Professor.
Thank you.
Alexandre, do you listen to us? We also have Alexandre Rezende.
Look like he's operating.
Yeah, he is. Yeah, he's definitely. Alexandre?
Can you listen to me? Hello,
Yeah.
guys.
Yes, yes, yes.
Yeah. Sorry, I had an operation here today that started very late, and I'm still dealing here. Is a tough Whipple, robotic Whipple. It started very late, and I couldn't finish it. Swanto, it's an honor to be
Yeah.
your friend, man. It's a really
Thank you.
every time I see your presentation, I see first of all a very very hardworking guy, and then a guy who's pushing limits of the minimal invasive surgery to places where we have never imagined to be. And I have just to congratulate you and to tell you that this is an amazing job. Do you have any special case that you still select to be done open on Klatskin, for
Yes.
example? When do you select a patient to do it openly?
So it's a very good question. So there are probably about at least 15, I would say 10 to 15% of patients we still do open. And this is actually a very, very hot topic when we had the consensus conference on robotic HPB in Paris, because obviously safety is number one, and we don't want to make an idea that everyone and every cases has to be done robotically,
Yeah.
because there are cases that will be better than open. So large tumor in the posterior sector, that's probably better than open, because the tumor manipulation with robotics sometimes it can crack the tumor, open the tumor. So the liver mobilization with a big tumor also very difficult. And you don't have your hands that you can really tilt the liver. Robotic is quite difficult to do. If you
I have
have,
myself. Sorry. Please continue.
if the second circumstance is a large caudate tumor with the IVC involvement, where the IVC needs to be replaced with the PTFE or Wolfen Dacron graft. The issue is not the suturing, but sometimes placing an upper cava clamp is not very safe robotically. If you see the transplantation, many of the the cava clamp is actually using an open clamp. Those are open German clamp that is placed into the abdomen through the gel port and is placed in a side bite fashion. It's an open clamp. And in robotic, the clamp is not very strong, especially for the upper cava. The lower cava is easy. You can put two clamps there, you have a lot of rooms. But the upper cava is a problem. So I'm sometimes I'm concerned to place an upper cava clamp robotically because I feel like the clamp wants to slide down. So I think those kind of cases, I think open is, at least for now, open is secure.
Oh,
For
right.
a glass skin tumor where you need to do a complex reconstruction, hepatic artery, portal vein together, I think open is probably still more secure than robotic. It gets so difficult when it's so complex. When it's straightforward, then it's easy. Uh, tumor that is close at the portocaval hepatocaval confluence. For example, large cholangiocarcinoma that involves the hepatic vein IVC confluence. Those are also difficult to do robotic because many times you get into the IVC and it's a problem.
All right. And I have some small series of Klatskin myself. I've done some cases. And one of the most difficult things for me is to define where to transect the tumor. I used the spyglass, but it didn't really help me because the imagery inside the spyglass is hard, however, for us to precisely define where to transect it.
Yeah.
And
Yeah.
sometimes we're afraid of getting compromised margin. We cut a lot of safe tissue that we could preserve in order to, as we can touch, we don't have the feeling. We go, we transect a little further than we should have done on the biliary tree. Do you have any feelings about that?
Obviously, the spyglass can only give you an idea, but it is not a definitive answer to this, because many times the bile duct looks very, very inflamed and it can back no cancer, and sometimes they look fine and come back with microscopic cancer. So I think a spyglass is only to show you the rough estimate of where the transection line is. The definitive transection line, you have to do a frozen section still. And this is not an uncommon scenario where you have to cut more than what you need to because you're concerned of cutting through the tumors. And in many times, for example, Claskin 3B, many times we end up having two anastomosis because they're so high because we're afraid of cutting to cancers. So this is something that I think still an ongoing problem.
Do you think ICG can help us somehow? I sometimes inject ICG inside the biliary tree to try to delineate where better place to transect it.
Until today, I have not found the ICG is very helpful in this scenario. Because many times the ICG is just too yellow and too green and didn't really differentiate the healthy and non-healthy part of the bile duct.
All
So
right.
we still rely on the frozen section a lot.
Fantastic, fantastic speech.
Yeah.
Thank you very much. It's amazing.
Thank you. Thank you. And also back to the training and education, I think there is a lot of what we call skill transfers. Transfers. It means you learn how to do the step in Whipple and you translate to a different operation. You don't have to learn from that specific operation,
Absolutely.
right?
Yeah, totally agree.
If you can do a distal pancreatectomy, it means you can do a splenectomy.
Sure.
If you can do a left hepatectomy, it means you can do left lateral sectionectomy. So there are a few things. If you can do a lymphadenectomy for Whipple, you can do lymphadenectomy for Klatskin tumor. So
You know,
in the training, this is how we train the resident.
Yeah.
We expose them to different stuff, and at the end, they will grab the different concept and put them together.
when you show the spyglass, you know, one image that came to my mind was when the guys do the esophageal anastomosis and bring the endoscope to check the anastomosis. So I say, well, maybe in the future
Yes.
we're going to use the spyglass to check on this difficult biliary anastomosis to make sure it's really well completed. But just some crazy thoughts. But one thing I want to ask you, please, is regarding a very big operation that is hepatopancreatic. So we just
HPB,
have
yeah.
mentioned Dr. Nagino from Japan,
Yeah.
and I don't know. This is a very controversial surgery, even for open surgery. So I don't know if you do recommend this in some cases, and if you do so, do you think this is another very big operation that maybe in the future can be performed safely robotically?
I've several cases of HPD done open, and the issue with HPD is I think you need to really select the patient for HPD, because HPD is a cases that has a high mortality. If you read the uh, published series of HPD, the mortality can be up to 25 to 30%. So I think the decision first to do HPD, it has to be put together with the patient condition, the complexity of the operation, and whether the patient can tolerate the operation or not. And if we take it further to do a robotic HPD, this operation will end up 15 hours. And because to do the liver part, it probably take 4 or 5 hours. To do the Whipple part, it will take 4 or 5 hours. And it can easily more than 10 hours, this operation. And I think one thing that the surgeon needs to understand is more than 10 hours of new peritoneum is problematic. Over the last 1,000 cases, I have many patients who are on the table 8, 10 hours. And those patients, sometimes they do have problems. We have patients who have a stroke afterwards. We have a patient with pulmonary embolism afterwards because of pneumoperitoneum and immobility for 10 hours. That can compromise the patient outcome overall. So I think HPD it's a definitely technical challenge for robotic, but I'm just worried about the time that it took to do it. Uh, the question is, which one is better? To do an open operation, you finish 7 hours, 6 hours, versus robotic, you finish 12 hours. At the end of the day, maybe the open one with 6 hours is better than to do it robotic 12 hours.
Very nice.
Is it doable? Definitely doable. There's no question. HPD is doable technically. But the question is it overall, is it better than open? That remains to be seen, I think.
Yeah, and regarding operation time, do you think for the younger surgeons or the learning curve period, do you think we should have some time limits to understand, or should still keep trying robotics? For example, have a first class, and let's say you do this in 6 hours in open surgery, 5, 6 hours. So do you think I should start with the robot and have like a time limit? If I reach it 5 hours and I'm still not very uh, forward at the operation, should I convert, or do you think there's no sense? You just have to push and be reliant.
I think this is a very important question. I think the surgeon needs to be aware of overall situation. So it means that if the operation is not making progress and you start having a lot of bleeding and it start to have a hemodynamic compromise, and you look at the time, it's like 5 hours. We are like barely finished with the duodenal catheterization and everything. That I think that case needs to be done open.
Yeah.
And it should not be a shame of having to do an open, because many of the robotic cases at the beginning are planned open. So if you look at the European surgeons back in the days, in the early 2015, 2016, they do the resection open, and they do the resection laparoscopic and make small incision and reconstruct it. So, and that is a very efficient way as well. So I think for robotic surgery, it doesn't make sense, especially in the learning curve, to persist and stay for very, very long time just to say that we can finish robotic. I think this has to be considered overall. Um, I know a surgeon who performed an inguinal hernia for 6 hours
Wow.
robotically, and the patient had pulmonary embolism and died postoperatively. That operation could have been done open in an hour and a half, and the patient will alive. So I think the surgeon needs to put together the time is important as well, uh, and use common sense. I think if the operation take more than twice as long as open, I think it is a consideration to be done open.
Very nice. Thank you.
Yeah, yeah. This it's very nice to hear that, because um, we see that a lot of people are starting on robotic surgery, and sometimes, as you said, uh, there's quite a shame in converting those patients to open surgery. But at the same time, you have to put in balance the time that you
Yes,
spend, like twice the time that you spend in open. How is it going to affect the patient? Uh, I have always thought like you, and it was very good to me to hear that from you, who is a
yeah,
board authority on the field.
yeah,
I
yeah,
thought I was
yeah,
alone.
yeah. So many of those patients, when you expose them with the pneumoperitoneum for 8, 10 hours, sometimes they cannot open their eyes.
Yeah.
Because they have a sub-Q emphysema to the scalp sometimes, and they cannot open for the eyes for 2 days, 3 days. We have a patient we put in the ICU because they cannot open the eyes for 3 days.
Oh, wow.
So
Yeah.
it is a real problem. I mean, eventually patient recover, but if you ask the patient, do you want to see for 3 days or you don't want to see for 3 days?
Yeah.
I mean, if you say, I want to see for 3 days.
Yeah.
So I think we need to be aware and use common sense of all of this.
A personal question. Which is the personal limit that you're still trying to reach or to overpass? Is there still something that you're seeking to go further in a personal
For
matter?
for 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 me, the next step will be robotic transplantation,
Okay.
because I think that is a lot of technical part that you need to kind of develop on the field by performing. I watch robotic left graft implantation
Yeah.
from Saudi Arabia, and I was so intrigued how the diaphragm on the right side was plastied in order to support the graft sitting, so the outflow doesn't kink. This kind of stuff that you have to you cannot learn in the book.
Yeah. Yeah.
You have
Sure.
to see it, and you have to see how it's sitting. Is it kink to the right, kink to the left? Those kind of stuff. Those are challenging, but eventually, once you do it, you will develop a standardized technique. A complex reconstruction in classic is also difficult,
Yeah, yeah.
and it is something, and each of the reconstruction are not quite the same.
Yeah,
Some
sure.
reconstruction are much harder than others. Some are easy, some are straightforward, but many of them are very extremely difficult. So I think we still have a lot of work to do to improve the technique. It's a lot of
Sure.
work to do still.
Yeah.
Yeah. So the learning keep going. It's not finished now.
Yeah, and do you think any of the new platforms are changing anything uh, or not?
I think right now, the Da Vinci is leading the way in complex operation, but the newer platform has been released as well. I use several of them in live patient as well.
Hmm.
It is still not as smooth as the Da Vinci, and it's a bit difficult to use. Uh, can it be used for Whipple? Yes. Can be used for liver resection? Yes. But it's probably needs some, I would say, refinement, because the movement sometimes is a bit not very smooth compared to Da Vinci. But can it be used? Yes. Can be
Okay.
used safely? Yes. But things are coming in the future because the number of robotic technology is developing very quickly. I don't think the company will make laparoscopy anymore in 5 years from now, because it's moving quickly toward robotic surgery.
Yeah. Yeah, we are thinking that. Alessandro Bellotto, any other final question? Because we're trying to keep in 1 hour and 15 all the lectures and questions. It's okay?
No, I'm great. Thanks
It's
for the invitation. Really happy to have this opportunity. Congratulations again to Candy and Juan for the organizing.
My
Thank you.
pleasure. So,
Yeah, thank you very much.
Bellotto, any final words? Any final
No,
question?
for me, the pleasure, Professor Scandi, the learning for you, and thank you, Nicolosi, in our invite for me.
Yeah, it's my pleasure. So, thank you again, Dr. Scandi. Thank you, Alessandro and Bellotto. Well, the lectures like the ones that we had today are the ones that make us keep on organizing this sort of course every year. Really amazing. And thank you very much because you were not in the States, you were on a personal trip, and still you are
It's
here
okay.
with us to, in our course. Thank you again
No
for all.
problem. Yeah,
You're a very
it's
nice
it's it's
person.
it's, it's always a pleasure.
Thanks. So, okay,
Yeah.
thank you very much. And for us, good night. And for you, I think a good day.
Yeah, thank you.
Bye-bye.
Thank you very much. Bye-bye.
Thank you, guys.
Okay.
Thank you. Bye.
Bye-bye.
See you.